Okay, so I'll go ahead and give you a quick introduction and then we'll get started if that's okay.
You bet.
Okay. All right. Good morning, everyone. Welcome to Grand Rounds. Today, we are very happy to have Dr. Reid joining us to discuss burnout and the delicate but very important topic of physician suicide. Dr. Reid completed his undergraduate medical school and neurosurgical training at the University of Florida. More pertinent to today's talk, he is the president and founder of the nonprofit Doctor Lifeline, with the mission to expose and correct the conditions engendering the high rate of physician suicide. Today, he will be continuing his mission by educating us about the scope of physician suicide and strategies to combat burnout. Without further ado, thank you, Dr. Reid, for being with us today, and I will let you take it from here.
Thank you for the invitation. I'd like to start by telling you a quick story. Once there was a monk who joined an order who required taking a vow of silence. He was allowed to say only 2 words every 10 years and only to his abbot. He found himself in a cold, dank cell, sleeping on a straw mat, working in a dark room, illuminating manuscripts, eating terrible food like gruel. 10 years slowly passed, and he finally had the opportunity to approach the abbot with his carefully chosen 2 words, which were bed hard. The abbot replied, "You're the only one to ever complain about something like that. Get back to work." Well, another 10 years slowly passed. He was aging quickly. Again, the conditions were terrible. Finally, his opportunity for another 2 words to the abbot occurred. His carefully chosen words were "food awful." The abbot said, "There's nothing I can do about that. I'll have to talk to corporate and see if they can make any changes. Get back to work." Well, the poor monk then resumed his next 10-year stint. Again, everything was terrible. If anything, it was worse than it was before. And finally, after a total of 30 years with the monastery, he approaches the abbot with his carefully chosen words, "I quit." The abbot glared at him and said, "Well, I'm not surprised. You've done nothing but complain since you started here." And that's a little bit what it's like for some doctors. I've been asked to give some slides, the accreditation slide, a disclosure slide, another disclosure slide for the state of Florida. The objectives of this talk will be to review the scope of the problem of physician suicide, identify the prominent modifiable contributory factors, and offer strategies to mitigate learned helplessness, burnout, toxic workplaces, and empower physicians using principles derived from positive psychology and real-world experience. One of my favorite visionary artists is Alex Grey. You may have seen some of his work on the covers of the Tool albums. He started as a medical illustrator and then moved to visionary art. He made a beautiful triptych called The Journey of the Wounded Healer that kind of summarizes where we're all heading. I think we start out with being a healer in our DNA. We almost seem fated to follow the path that we do. We enter medical school and residency with idealism, goals, and purpose. But along the way, we're confronted with our own mortality. We're confronted with a materialistic, physicalist worldview, and we begin to see ourselves and our patients as collections of organs. We're exposed to violence, disease, and death. And this can take a terrible toll on young physicians and others who have to care for patients who have these serious illnesses and injuries. If we're successful, we're capable of integrating our experiences and moving on and becoming a force for good and healing in the world. But sadly, some of our colleagues are unable to complete the journey of the wounded healer and leave the path via suicide. We have a real problem with physician suicide in this country. About 400 physicians per year take their own lives. This translates into approximately 1 million patients per year who lose their physicians to suicide. To put it in perspective, on rates of 100,000 per year, the general public has a suicide rate of 2.3. California prisoners have a rate of 26. Veterans and military have a rate of 30, but doctors have a rate of 40. Male doctors have an incidence about 1.5 times the general population, and it's worse for female doctors at 2.3 times the general population. Suicide is the second leading cause of death for doctors, probably in the age group that I'm speaking to today, following only accidents. So this is a very, very serious issue, and it really doesn't receive the attention it deserves. A recent meta-analysis showed that US physicians were at a higher risk than the rest of the world by 34%. Talbot and Dean, in one of their papers, reported physicians are the canaries in the healthcare coal mine. They're killing themselves at an alarming rate, twice that of active duty military members, signaling something's desperately wrong with the system. So, what's wrong with our doctors? Why are they killing themselves? I'm going to try to make the case that major factors contribute to toxic practice environments, and that these factors lead to debility, dependency, and dread. Those are important words, and we'll come back to them several times. Now, there are many factors contributing to toxic practice environments, and we don't have time to go over all of them. But I'd like you to take a brief moment and look at the list of some of these, and we're going to be hitting on them in a few minutes. Here is hostile workplace. OSHA has reported that nearly 75% of all workplace assaults happen in the healthcare industry. Healthcare accounts for nearly as many serious violent injuries as all other industries concerned. 80,000 US healthcare workers are assaulted each year. So this makes for a very hostile workplace, and everyone that works in healthcare knows this. This leads to one of those D words, dread. Many people dread coming to work because they know that it's a dangerous place. This is one of the conditions that leads to burnout. And I think we all know physicians who have suffered from burnout or are suffering from it. And many of you hearing this today probably are undergoing it right now. The World Health Organization recognizes burnout as a specific medical condition. It's characterized by feelings of energy depletion or exhaustion, increased mental distance from one's job, or feeling of negativism or cynicism related to one's job. And it results in reduced professional efficacy. The term started in the 1970s to describe end-stage narcotic addicts. It later was adopted to apply to overachievers, and it was first used in the medical literature to apply to physicians in July of 1981. It's been getting worse. According to researchers at the University of California, physician burnout increased from 45.5% to 54.4% between 2011 and 2014. Since then, it's continued to progress, and we don't really have the latest statistics from the effects of the COVID pandemic, but it's undoubtedly a lot worse than it was then. So we're talking about probably more than half of physicians have some degree of burnout. Who's it worse for? It's worse for women. About half of female doctors have reported feeling burned out. This corresponds to the suicide rates as well. When asked about what contributes most to burnout, too many bureaucratic tasks such as charting and paperwork leads the list. Then there are long work hours. EHRs really aggravate people and also contribute to burnout. Lack of respect from colleagues, insufficient payment, loss of autonomy, et cetera, regulations. So there are a lot of things that contribute to it, but the bottom line is it terribly affects physicians' well-being and their performance. How do work hours correlate with burnout? There's a direct correlation. Physicians who work less than 40 hours a week have a 36% rate of burnout, whereas those who work 71 or more hours per week have a 57% incidence of burnout. Who's more likely to work these long hours? General surgeons, cardiologists, urologists, pulmonary medicine, nephrology, critical care. And these are some of the specialties that have the highest rates of physician suicide. Interestingly, emergency medicine has some of the shortest work hours, yet it has some of the highest suicide rates, probably related to the intensity of exposure to violence and trauma. Now, speaking of long work hours, we're all familiar with the stereotype of the Japanese businessman that comes to work early in the morning, works all day, tries to please the boss, and then still has to entertain his fellow employees after work hours, becoming exhausted. The Japanese have words because this is a common enough issue in their society that are specifically related to this. Karoshi literally translated means overworked death, where these poor folks actually literally drop over dead at work. And then karo jisatsu is a word for overworked suicide, which is a related condition. So long work hours, such as the Japanese businessman and the US doctor, contribute to physical and mental exhaustion, which brings us to another one of the D words, debility. Now, before your time, probably back in my day when men were men and women were women and giants walked the halls, it was not unusual for residents to put in greater than 100-hour work weeks. In 2003, there were some changes that began to be made that were modified as recently as 2018, where now there is an 80-hour work week cap and a cap on the consecutive number of hours that a physician resident may be expected to work. Interestingly, there are no restrictions on post-residency practice hours. There are a lot of physicians in the community, a lot of attendings on staff that put in much more than 80 hours each week. Another one of the many factors that may be contributing to this epidemic is moral injury. Now, this is a situation that was first described for soldiers' actions during war. It represents perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. Doctors often find themselves at the intersection of competing interests. They experience pressure from countless parties with differing agendas and are pulled in several directions. Administrators and insurance companies try to direct, command, cajole doctors into actions which benefit the corporation more than the patient. The doctor knows he may be asked to do something that does not conform to his or her own morality, and this is highly stressful for an individual. Another factor is the expectancy of stoicism. Everyone falls into this culture that the doctor is stoic and resilient. Doctors confront human pain and suffering every time they go to work, and this exposure exacts an emotional toll. The culture of medicine affords low priority to the mental health of doctors. In many medical circles, it's simply taboo for the doctor to discuss his or her own emotional issues, and many doctors find they have no place to discuss or vent their distress. So later on, we're going to talk about some ways that we can improve on that particular factor. But this, again, leads to dread. The doctor just approaches every day knowing that he may be exposed to something even more horrific than what he or she saw the previous day. So another factor is depression. And this is highly tied in to burnout, although it is distinguishable using various psychological instruments and surveys. But there are a lot of depressed doctors. The question comes up, are physicians burned out or depressed? And the answer is that about 15% of doctors at any given time are actually depressed, and another 44% are burned out. Now, burnout itself typically is not associated with physician suicide. However, it is associated with depression, and depression is highly associated with physician suicide. In a survey where doctors were asked, does depression affect patient care, 53% considered that it did. 47% said that it didn't affect their interactions with patients, but 35% said that they easily became patients, that they were less motivated to take good patient notes and take time filling out the EHR. 16% blew up in front of their patients, and 14% confessed to making errors that they might not normally make. So depression has a serious impact on patient care. When asked if the doctor planned to seek help for burnout or depression, 36% planned to or did seek help. 64% did not. So there's a large reservoir of untreated depression and burnout within our ranks. And this is something, again, we're going to talk about a little bit later, but we can help each other to identify those of us that are having these issues and to motivate appropriate treatment. Many doctors don't seek treatment for a variety of reasons we're about to discuss, but almost 1 in 5 physicians have obtained or considered obtaining secret mental health care. Why don't doctors seek help? Well, we have fears about the effects on our referrals, what will happen to our reputation, is my license at risk? Will I have problems obtaining life or health insurance? So these factors again lead to one of the D words, dread. But these fears are rational. These fears have a basis. So the overall situation we find ourselves in is kind of a double bind. One path potentially leads to death, and the other potentially leads to loss of career. For example, the Florida Medical Board, when applying to become a physician, there are 6 relevant questions to our talk today. 3 relate to substance use and 1 to physical impairment. There are 2 mental health questions, though. In the last 5 years, have you been admitted or referred to a hospital, facility, or impaired practitioner program for treatment of a diagnosis or diagnosed mental disorder or impairment? And during the past 5 years, have you been treated for or had a recurrence of a diagnosed mental health disorder that has impaired your ability to practice medicine? So neither of these questions actually focus on the doctor's current condition, but rather on their mental health history. And you can see that a yes answer to any of those questions demands a very extensive response, requiring medical records, DSM diagnoses, codes, admission dates, discharge summaries, etc. So this is a very highly invasive type of question that can certainly scare doctors away. And it emphasizes the dependency the doctor has on the medical board to continue to maintain his or her career. Now, there has been some progress recently. Uh, there's a group of deans of medical colleges that have been lobbying medical boards throughout the country to correct these scenarios in which the physicians are disincentivized from reporting mental health issues. And the Florida board has actually been working on this issue for more than 10 years. But finally, they went so far as to add this preamble. Seeking assistance with stress, mild anxiety, situational depression, family or marital issues will not adversely affect the outcome of a Florida healthcare practitioner application. The board and the department do not request that applicants disclose such assistance. So that's a step in the right direction, but the previous language I showed you is still on the books, and some may argue that it actually is in conflict with the preamble. But at least there is some progress in making this a little less onerous when it comes to seeking help when in a particularly difficult situation. Another factor contributing is social defeat. Have you ever been in a situation where you had a particular strength, you had a signature strength? Maybe you're really good at computers, maybe you are very good at integrating information, or maybe you're just an idea person, and you bring it up and you're immediately shot down in flames. Well, this is a frustration of your signature strength, and it's a form of workplace bullying. Now, there are several specific ways in which workplace bullying can progress, and there's a typical pattern. Usually at stage one, there may be some indirect aggression with gossiping or backbiting. This is the microaggression stage. And then this frequently can progress to verbal confrontations, social rejection. You know, the person's just not part of the clique or the group. You know, that guy we just can't trust, etc. But the end stage of this is attempts to force the victim out of a job. And sadly, I can personally attest that I have seen this happen to good doctors. Over the course of my career, I've known at least 2 doctors who were excellent physicians who fell victim to this type of situation and ended up losing their jobs because of workplace bullying. This has a serious impact. Each person has a self-image that relies on others to provide a mirror to reflect back to them. And if the ultimate threat is one of job loss, which involves economic harm, career damage, and fear of future losses, the end effect is quite similar to PTSD. And analysts of social defeat and bullying indicate that there are incredible parallels to PTSD, including depression, loss of self-esteem, anxiety, sleep disorders, and psychosomatic disorders. So in situations where you may see the dynamics of social defeat playing out, see if you can intervene. Again, this leads to the D word, dread, which makes it hard to come to work. Loss of autonomy tends to affect us older doctors more than the younger doctors, because we older doctors grew up in an era where we could have our own practices, our own businesses, our own offices. The vast majority of physicians coming out of training these days become employed physicians working for large groups or for hospitals. Dr. Waters pointed out physicians by nature crave autonomy. We are educated and trained to be independent thinkers, to evaluate, cogitate, ratiocinate, and make decisions, most of them difficult and often critical. The quantity of misery is proportional to the degree that this hard-won autonomy is taken away. We all have undergraduate medical doctoral degrees. Many of us have additional master's degrees or PhDs, plus years of intense postgraduate training and real-world experience. Having decisions made for us by individuals with far less education, training, and experience is more than a bitter pill. Worse yet is the physician in name only, often a physician who feels compelled to find fault or seeks fit to pass judgment on those who are actually taking care of patients. So this loss of autonomy is an incredible insult to some that constitutes a true loss and is therefore felt as a loss and is harmful psychologically. This next area is one that I'd really like to focus on because this is one that I think really exemplifies the core issue that if we can focus on it, I think we can make a big difference. And I don't think it's had enough attention. And that's the phenomenon of learned helplessness. This cartoon kind of points out what learned helplessness is all about. You try things and you don't get anywhere. And after a while, you just stop trying. You wait for someone else to make it happen. And this is a bad place to be. This is Dr. Martin Seligman. He's the father of positive psychology. More about this later. But he is the discoverer of the phenomenon of learned helplessness. He developed a laboratory model for depression. His classic experiment involved an escape task. What he would do is place the experimental or the control animal in a shock box. He used rats and dogs. He would place the animal in the chamber, flash a light or a buzzer, and then administer a foot shock to the animal. The animal could escape the shock by jumping over a small barrier. That was the situation for the control animals. The experimental animals would get a shock no matter which side of the barrier they were on. And if they jumped over it, they still got the shock. So very quickly, after just a few cycles, the experimental animals no longer would try to escape the shock. They would see the bell, hear the buzzer, and get the shock. They could even observe other dogs escaping the shock, but they instead would just sit there and whimper. He called this phenomenon learned helplessness. Interestingly, he found that if a researcher would physically move the dog from the shock chamber to the no shock chamber, after just one or two trials, the animal would then learn that, yes, I can escape the shock. So just knowing that there is an option is incredibly motivating. And think about that when you find yourself in a situation where you're beginning to think, well, there's just nothing I can do. There's no way I can get out of this. Now, I'd like to point out that learned helplessness is understood by many people at many levels of society. And it's actually the goal of the violent in our society. Violence is the purposeful infliction of psychological or physical injury. The goal of violence is to deny the victim the option of saying no, such as to the question from the mugger, will you give me your wallet? Or from the administrator, will you add more diagnostic codes so we can make more money? Elements of the current medical practice environments work to deny the physician the option of saying no. This is a form of psychological violence, and it's intentional. And you need to recognize it when it happens, and you need to point it out. I have a favorite author, Robert Anton Wilson. He writes some really wild sci-fi, and here's one of his quotes. The ultimate weapon isn't this plague out in Vegas or any new super H bomb. The ultimate weapon has always existed. Every man, every woman, and every child owns it. It's the ability to say no and take the consequences. So you are in possession of the ultimate weapon. This is an experiment that I thought was very interesting that could never be done today, thank God. But back in the 50s, Kurt Richter performed an interesting, if not sadistic, experiment using rats. And in his experiment, he took wild rats and placed them in a chamber that involves cylinders with jets of water that came down on the rats. And what he would do is turn on the jets of water, and the rats would have to swim to keep their noses above the waterline to stay alive. He did one experiment just to see how long the rats would survive doing this. And on average, the rats would give up and sink and drown after about 15 minutes. But then he did a second experiment that was very interesting. He would allow the rats to just approach the level at which they would be drowning after several minutes. And then he would rescue the rats and pull them out and dry them off, let them rest and catch their breath. And then he would put them back in the chamber. How long do you think those rats would swim? 15 minutes, 30 minutes, an hour? Turns out that those rats would swim for an average of 60 hours after the rescue. So I think this reflects what may be the opposite of learned helplessness, and that would be learned hopefulness. So that a single significant intervention made an absolutely tremendous difference for those rats. Now, ultimately, Dr. Richter allowed them to drown after 60 hours, so I really don't have a lot of respect for the guy, and I'm glad that kind of experiment wouldn't happen today. So we've been talking about debility, dependency, and dread. I'd like you to read something that actually came from a CIA interrogation manual. The manual characterized learned helplessness as apathy, which can result from prolonged use of coercive techniques, resulting in a debility, dependency, dread state in the subject. They said if the debility, dependency, dread state is unduly prolonged, the arrestee may sink into a defensive apathy from which it's hard to arouse him. So a lot of the things that we experience in our normal practices in our healthcare environments have actually been used by the CIA in dealing with arrestees, but they say not to go too far or you won't get the information you need from that guy. So all this has been kind of dark, and I'd like to change this a little now. How can we escape from these untenable conditions? I'd like to show you that there are some ways out, and I think that we need to use them. The first thing I'd like to suggest to you is psychological immunization. Write a letter to your future self and put it somewhere where you can find it. Include in that letter your motivations. Pretend you're applying to medical school again. Why are you doing this? Why do you want to? What is it about the field that attracts you? And then counsel your future self. Say, look, you knew this was going to happen. That's why I wrote this letter. So let me talk you out of doing anything bad. Let me talk you into getting help if you need it. You could save your own life with the psychological immunization of writing a letter to your future self. So please, this sounds very simple, but it's highly effective. Put it where you can find it in times of stress. The second suggestion comes from the military. Now, the military obviously deals with stress at incredible levels. Interestingly, emergency room exposure to trauma and violence is often worse than what soldiers experience on battlefields. It's certainly a lot more continuous. But the military has determined that the battle buddy concept is very effective. You find somebody that you trust, you have a confidant, a friend, a colleague, and you look out for your other colleagues. And everyone is kind of responsible for everybody else. You identify your friends and colleagues who are in stress, who are having problems, and you act, you intervene. So the concept of battle buddies actually translates very well from the military to the medical practice. So what do you look for in a battle buddy? That people always have these little acronyms. The military likes you to be brave, accountable, trusted, truthful, level-headed, and encouraging. And most of those translate well to a clinical battle buddy as well. More on positive psychology. Remember Martin Seligman. He is considered to be the father of positive psychology. He made a very interesting observation. He was coming into the field kind of at the end of behaviorism, and he realized that in the field of psychology up to that point, most of the focus had been on pathological states. It was on depression, on phobias and so forth, social adjustment disorders and things. But the focus was on pathology. And he made an analogy. He said, if I were gardening and all I did was pull out the weeds, what I would just be left with is bare ground. He says, if I want to have a garden, I need to plant some flowers. And so he made the point of creating this new field, essentially, of positive psychology, that he wanted to catalyze a change in psychology from a preoccupation only with repairing the worst things in life to also building the best qualities in life. So this literally was a sea change in the field of psychology, and it's really gaining traction now. And the military and many other fields have adopted his principles. I highly recommend, if you're unfamiliar with him, to research him and read some of his work. Then he goes beyond simply identifying and promoting the good things. He says, just as the good life is something beyond the pleasant life, the meaningful life is beyond the good life. And think of how blessed we are, how meaningful our lives can be as far as the interventions we can make in the lives of others. We're uniquely positioned to be able to do that and have meaningful lives. Remember earlier I talked about a frustration of a signature strength. Martin Seligman identified 24 specific signature strengths that he thought were particularly important for people and need to be identified and developed. And there's nothing more pleasing and rewarding in life than exercising your signature strength. If you're a good musician and you get an opportunity to play your instrument and you enjoy it, that is exercising a signature strength. If you're an unusually good diagnostician and somebody comes to you with a difficult case and you can identify it, that's exercising a signature strength. Now, again, sometimes people try to prevent you from exercising your signature strengths, and you need to resist those efforts. Identify that. That's a form of workplace bullying. If you're interested in exploring more about your own signature strengths, there's an online instrument at this VIA Institute on Character that you can take in about 15 minutes. It's free, and it ranks your signature strengths. So you can see what you're probably best at, and it can show you areas where you may need to provide some effort to enhance. Okay, next on the list of things you can do to really improve and escape from the situations we may be finding ourselves in are the 3 good things concept. Brian Sexton at Duke provided this, this material, the Three Good Things program basically consists of taking minutes at the end of the day and recalling three good things that happened during the day. So maybe a moment of beauty appreciation. Maybe you had a great meal, or it was really pretty looking out the window. You got a call back from somebody that you have been trying to reach for a long time. But just bring those things to mind. Now, the reason this works probably relates to our evolution. Normally, it's probably not good on an evolutionary scale to be optimistic all the time. If you're walking through the savannah looking for berries and rabbits, and you're not thinking that there may be a tiger or a lion hiding in the grass ready to jump on you, you might not survive to have evolutionary progeny. So there's a survival advantage to kind of always be looking out for what might be going wrong. But that wears on us, and it's really probably not appropriate for the kind of society we have now. So if you actively bring optimism to the picture, you can help counter some of that. So in their experiments, what they would do is have an experimental group consider the three good things at the end of each day for 15 days. And then they had a control group that just didn't do that. And they used instruments to gauge happiness and depression. And very interestingly, the control group remained stable, but the three good things group had strong effects, statistically significant effects on the happiness scale, extending out to 6 months, and it was continuing to improve. You'll see that there was a definitely upward trend. Brian Sexton reports that this actually persists for over a year. I mean, just consider this as non-pharmacological treatment for just 2 weeks, 5 minutes a day that has an effect that lasts up to a year. Similarly, for depression symptoms, you can see the effect on the symptoms of depression were still statistically significant at 6 months, and again remained statistically significant at a year. Such a simple intervention, but so effective. And there's a lot of talk these days about work-life balance and how to avoid the road to burnout, we need to work on work-life balance. Here's a Dilbert cartoon. Welcome to Dogbert's seminar on work-life balance. First, review your list of priorities: family, job, exercise, vacation, must-dos, medical, eating, hygiene, sleep, romance, holidays. So Dogbert says, you have time for three things. Work and holidays are two, so you get your pick of the third from that list. So work-life balance is defined as the amount of time you spend doing your job compared to the amount of time you spend with your family and doing things you enjoy. During my training, I heard about the AAA rated surgeon all the time. This came up again and again. The 3 A's are ability, being able to do the job, knowing your stuff, gaining skills and applying them well, able to give care, show care, and to just care. Being affable, keeping a good spirit, one of optimism and openness, keeping your cool, being a good old boy who can get along with everybody, and affable, showing up, being there, being present, being accounted for, being in the moment. Now, all these are good advice. There's no question about that. And if you can maintain that, you're going to be a superior physician and very much in demand. But you have to remember, you can't do a good job if your job is all you do. So here are a few tips for finding work-life balance. We want to look for purpose, time management, prioritization, reassessing, and resetting. So under purpose, keep your passion. Don't lose sight of your goals. Find meaning in your work, but remember that should include yourself and your family. Align your personal needs with those of your organization as much as possible. And remember your psychological immunization that we talked about earlier. Time management is a big one. So set short and long-term goals, but remember that no plan survives first contact with reality. Remember, urgent doesn't always mean important. More on that in a moment. Organize, make plans, but remain flexible. Identify and avoid time-wasting activities. Now, this is a big one. We have so many distractions available today. There's this phenomenon of FOMO, or fear of missing out, or we may return to our email or our news services because we're afraid we're going to miss the latest in whatever. Use your templates honestly in your EHR, but leverage them to save yourself time. And when you can, delegate. Prioritization of your tasks. Remember, you're important. You need to prioritize yourself. Your family is important. There's the phenomenon or the technique of satisficing. We often look for the best solution to a problem, but that's not always necessary. We can sacrifice the perfect to the good. That you may, rather than wasting a lot of extra time to get the perfect solution, just find one that works and go with it. Sometimes problems solve themselves. If they're not too serious, they can sit around and maybe they'll go away. There's a great book, if you haven't read it, it's called House of God. Every medical resident should read it. One of the great lines from that is, the first thing to do in a code blue is to check your own pulse. So regarding prioritization, the difference between important and urgent, recognize that there's a big difference. Things that are important but not urgent, you can decide when you want to do them. If they're urgent and important, you better jump on them now. If they're not important and not urgent, just do it later. And if it's urgent but not important, you probably can find somebody else to do it. And we're all going to have moments in our lives when it's time to reassess and reset. You're going to experience life transitions, marriage, childbirth, sometimes divorce, death of loved ones, lawsuits, humbling outcomes, positive or negative changes in your self-esteem. And these are inflection points that give you an opportunity to reassess your work and your life and to try to bring them into a greater degree of balance. Okay, so those were all the important things about work-life balance, but now there's a new thing on the horizon, and it may be the next evolutionary step, and that is work-life integration. So again, back to Dilbert, says we're no longer using the term work-life balance because it implies that your life is important. We now call it work-life integration. So it's easier to make you work when you'd prefer being with your loved ones. And then Catbert says, and I'd like to give a big thanks to those of you who never had a life. Dilbert says, you're welcome. So you'll encounter people that say you need to work more on your work-life balance. But again, you're overworked already. So the pursuit of work-life balance can actually worsen a physician's quality of life by adding additional, often unrealistic expectations to their already stressful lives. Jack Welch said, there's no such thing as work-life balance. There are work-life choices, and you make them, and they have consequences. So I'd like to wrap this up now with just 3 slides that are from Dr. Andreas Schwingshackle that I think really summarize this in an important way. He says, if as physicians we stand behind the personal statements we wrote as medical students and our eloquent speeches during job interviews, describing that special day we realized we were destined to become a doctor and care for sick children, then we all clearly chose this profession out of free will. If that premise holds true, then the hours spent treating sick children are part of our lives just as much as the hours sipping on a glass of wine, going on a family vacation, or fishing with our buddies. Suddenly, the border between life and work vanished. Work became life and life became work. We all have some better and some worse days, but as physicians, by the end of each day, we will have made a difference in at least one child's life. If at that moment we pause for a second, acknowledging this incredible achievement, recognizing that we made this world a better place for somebody today, we will experience the indescribable privilege of feeling balanced every day. And then he paused and said, 2 children died last night during my call in the ICU. One family saved the lives of 4 children by donating their son's organs. The other family told my team what an honor it was for them to meet us, and that they will never forget how we helped them cope with the tragic death of their 12-year-old daughter. I'm tired, exhausted, and hungry, but right now I am balanced. I'd be happy to take any questions or promote any discussion at this time that we can do.
Yes, hi, good morning. This is Jeff Moisey, Dr. Moisey. A very great talk. I see that we focused on the physician. What do you think that institutions can do to help their physicians to achieve some of the goals that you've discussed?
I think, let me advance to a couple slides here because we have some plans at intervening at different levels, and the institutional level is one of those. So I'm going to just quickly scroll through here. Okay, at the institutional level, I think what we need to do are review policies, see what's in place, as far as how does the institution relate to the physician? Is the institution welcoming to the physician? Does the institution provide appropriate incentives and benefits and pathways for the physician in their policies? Does the institution have a pathway for stigma-free complaints? Remember our monk at the beginning, the abbot said, no one has ever complained about that. Well, jokingly, I would say that you need to know two things to be a hospital administrator. The first is that you can respond to any doctor with a complaint by saying, well, you're the only one who's ever complained about that. And the other thing you need to know is that if the doctor comes to you with a good idea, all you need to say is, well, that sounds great, but we're going to have to run it by corporate first. So you need to have a pathway at the institution for stigma-free complaints. You want to look at the institution's culture. Is it one where everyone is expected to be stoic and resilient all the time if you're a physician, or is it one that accepts our humanity and our weaknesses, and work on the culture? Interestingly, the slides I showed you from Duke with Brian Sexton with the three new things, that was part of a program that you can actually get through the Florida Medical Association and the Florida Hospital Association. There are, I think, 20 lectures. The series is called Building Resilience. So again, the implication is that if there's a problem, it's the doctors aren't resilient enough, which is a cultural thing. As we've shown here, there are a lot of problems that extend way beyond the doctor's resilience. Does the institution provide support? Is this something that the doctor can feel comfortable going to the institution for help? Or does the doctor feel that he has to go off-site to a different county? The Medical Society in Jacksonville actually has a kind of a pilot program where their at-risk physicians can seek help off-site in another county to kind of maintain their privacy, because obviously loose lips sink ships. There's a lot of gossip that goes around within institutions, and so that's one of the reasons that doctors rationally fear bringing up their needs at their local institutions. EHRs still remain awful. There's plenty of room for improvement institutionally for electronic health records. We touched on confidentiality concerns and the use of external referrals. So those are some of the things that we can do at the institutional level to help our doctors.
Thank you.
You're welcome. Are there any other questions?
Hi, this is Dr. Gonzalez. I'm a third year for OBGYN. I really enjoyed your talk. Thank you very much.
You're very welcome.
In that aspect of culture, like we did the ACOG wellness, we did a wellness modules and they were amazing and they were really good. But when you try to put them to practice, when I tried to put them, let me speak for myself. When I tried to put them to practice, I received a lot of judgment from what I believe were, the hospital staff. For example, they taught us to take care of ourselves first. And that also includes physical physical care of ourselves. And I was in this surgery where it was like more than like a 5-hour surgery, and I asked for a bathroom break because I really needed to go and drink water. And the attending was completely fine with it, but the scrub tech was so annoyed, and everyone that like the nursing and the like actual OR staff was very, I felt very judged by them. And it's part of like that culture. Like the attending was taking breaks as well because it was a very hard surgery. We were dealing with a lot of stuff. And how can we address those changing that culture in all of the staff, not only the physicians and the attendings?
That's a very good question. I think it has to be attacked at two levels. One is incremental, and it's okay when someone confronts you with something that you would interpret as being a cultural expectation like that, to say, okay, look, I'm human. I need to go to the bathroom. This is not a sign of weakness. I'm a mammal. This is what mammals do. And, you can direct that at the individual level. If it's a repetitive issue, then you may have to take it up the ladder. If it's a specific individual that needs an attitude adjustment, then that may be required. As far as the more glacial or tidal big term changes, I think that's going to be slower. That's going to actually require kind of like the advancement of science. A new theory doesn't necessarily take hold until the proponents of the old theory die off, and it may take a generation for these changes to effectively occur. But we have to be patient and we have to work on it. We need to be forces for change.
Thank you so much.
You're welcome. Are there any other questions?
It's Dr. Goldzer. I'm the hospital administrator on the call.
Yes, sir.
And thank you very much. I thought it was a great talk and very, very helpful and very good. So thank you very, very much.
Okay, well, I apologize about my references to administrators.
No problem. It's not a
forgive me, sir.
problem. Not a problem. I feel very proud to be a hospital administrator. It's not a problem. It's
Well,
good.
you guys do a great job, and
And,
I think
just let me finish my comment just
You
one
bet.
second. So first of all, thank you. And I thought you hit a lot of great points. And it's the culture part of things, and what physicians are asking about is incremental. And we like to think that talking to your attending, if it's your resident, talking to your program director, talking to your chairman, and there is a ladder, and there is things that if you are concerned about things, you should raise them. It's this culture of, if you see something, say something. And we really want to get to that. We've tried to do a lot of training. Somebody referenced ACOG training. We have other AMA training that we do, but we do really want that type of culture that you describe. And thank you very much for for putting this together.
Oh, you're very welcome. I consider it an honor to have the opportunity to present it, and I'd be happy to take this show on the road anytime. If anyone would like a similar presentation, I'm very happy to do it. Anything else?
Dr. Reid, it's Cynthia Rivera. How are you?
Hi, Cynthia. How are you?
So nice to have you with us after almost a year of chatting with you. And I really appreciate you bringing this topic to light. It's a passion project of mine. I think the pandemic has really, ironically enough, there was a stripping away of all of the other factors at play in medicine that connected us with our personal statements in medical school and residency, where we were connecting on a humanistic level with patients and really reignited the meaning that we want to see in our work. And so I really look forward to collaborating on incremental changes in culture to make sure that we stay connected to that in healthcare and in medical education as we go through. So thank you.
You're very welcome. Thank you. Anything else? Okay, well, thanks again for the opportunity to make this presentation. I hope it helps somebody. And you can find Dr. Lifeline online at drlifeline.org. And I'm available. Drop me a line if you need someone to talk to. Here I am. And anything we can do to promote this, I'm willing to do. Thank you.
Dr. Reid, thank you so much. Thank you everyone for joining for Grand Rounds. That's going to conclude our session for today. I hope everybody has a nice Friday.